and welcome to the podcast on becoming a healer. This podcast is one where we discuss keys to becoming an effective healer in medicine. Each episode, we touch on topics like boundaries, judgmentalism, being realistic in the process of trying to make a difference, which is going to be one of the themes for today. I'm Stefan Karates. My co-host is Dr. Saul Weiner at the University of Illinois at Chicago and the author of the book on becoming a healer. One person featured in that book is Dr. Naina Bhalla, who is our guest today. Dr. Naina Bhalla is a physician with training in both medicine and pediatrics. She finished her residency in those subjects in 2006 and then did a fellowship in international emergency medicine, along with a Master of Public Health. She's worked in countries around the world, from South Sudan and Ethiopia and Madagascar, Amman, Jordan, Bangladesh, and Haiti most recently, many of those with the organization Médecins Sans Frontières, or Doctors Without Borders. Saul, my co-host, was actually her program director and wrote about her in his book on becoming a healer. Hello, Naina, and welcome.
Hi, thank you for having me.
And by the way, hi, Saul.
Hi, Stefan. Hi, Naina.
So we want to definitely just learn some of the facts of your background and work. And I will set up that in some ways, the topic of the chapter where you're mentioned is about being realistic in the process of trying to make a difference. And maybe that theme will come out. But I wonder if you can tell me a little bit about where you grew up and how you decided to become a doctor.
I grew up in Long Island, New York, just outside of Manhattan. And I don't really know, I can't say that I can't remember consciously making a decision and knowing at any point that I was going to become a doctor. I am Indian, and my sister and I were the first generation born in the United States when my parents immigrated here in the late 60s. And I think being Indian immigrants, my sister and I had kind of the general choices of either going into law, going into science or medicine, or going into engineering. And I think for me, I knew engineering and law wasn't going to be something I would be particularly interested in. And I think I just started I enjoyed science, I enjoyed biology. So I think when I was in college, I just started doing some of the prerequisites to go to medical school, although I still wasn't 100% sure if that's what I wanted to do. I think what probably solidified my decision to go into medicine was after college, I took 2 years off, but I did a program called AmeriCorps, where I worked at a free clinic in Los Angeles for a year for AmeriCorps, and then stayed on another year working there as an employee. And I did that because I, again, wasn't sure whether I was ready to commit 10 years of my life to becoming a doctor and whether I had that in me. And so I did this experience to kind of try and get out of my comfort zone and see if medicine was something that on a daily basis would be something that I could continue to do for my life, and to commit the amount of time that you need to commit to medical school and training, that I was ready to do that. So I think probably that experience solidified things for me into deciding to be a doctor and continue on the path to medicine.
Do you remember anything about how you felt doing AmeriCorps that mattered to you or affected you?
Yeah, a lot. I think for me, it was getting out of my comfort zone, going somewhere completely different. I moved from New York to Los Angeles, all the way across the country. I was by myself, but I was still kind of within a community because there was a small group of people that were also doing AmeriCorps in Los Angeles and other types of NGO work. And we lived together and spent time together. And I think that, we were all earning very low wages doing AmeriCorps. So being 20-something years old and and living in Los Angeles, but making a certain wage, we had to be inventive and creative about distracting ourselves and finding interesting things to do. And it was very nice to have a fulfilling job, feel like I was making a daily difference, seeing other things that could be accomplished with medicine than you're typically used to. And then also kind of feeling like I was part of a little community as well, working with AmeriCorps.
When did you begin to get any sense at all that some of your future work would involve work in other countries?
I think that before I went to medical school, I also took a trip to Central America, to Guatemala, and spent over a month there doing Spanish immersion classes and traveling a bit. And I really enjoyed that experience. And I think once I started medical school as well, I also chose to go to a medical school that offered a different type of experience. I went to Howard University, which is a traditionally Black African-American college and medical school. And so I had I would say, a specific medical school experience than for some other people, a typical medical school experience. So I was exposed to not only, different Latinos and African Americans from the United States, but there was also some international students from Africa in my class. And I think just being in that environment, working at a hospital that served an underserved community as well, kind of sparked my interest to try and continue on the path of kind of medicine as public service. And then, I did a trip when I was in medical school to Cuba for one of my rotations in my 4th year. And again, just the experience of going somewhere different, putting myself a little bit out of my comfort zone, and kind of seeing medicine in different countries and how medicine can be offered and how it can be structured in different ways in different countries, I found very interesting.
Yeah, there's sort of a question in my mind about translating what you know as a clinician to another setting and to another people who have different expectations and needs. Did you have any sense that it was a tricky task just to move what you knew into a whole new context?
I think I didn't fully grasp it until I did my fellowship, because when I was in medical school and I went to Cuba, I also did a rotation in residency where I went to Ghana. And in both of those experiences, I felt like I was still a student. So I didn't feel like I was operating as a doctor or, independently. I felt like I was there as a student to observe and to learn and to kind of soak it in, as you would say. But I think when I started to do my fellowship and I had to find and create projects for myself in the States as well as outside of the States, and then going to those places and trying to find something that needed to be worked on, find an objective, find a problem, and then to see if there was a way that we could work with the community or work with the NGO, wherever I was or whoever I was working with. That's when I started to see it on a kind of a project basis. And then when I started doing MSF as a clinician is really when I learned about taking my training, taking the medicine that I had learned and practiced into a completely different setting, and how I could translate that and still be effective is probably in South Sudan, my first mission, where I really kind of grasped what it was to be a doctor in another country.
Yeah, I think I want to ask about both of those. In terms of being effective in South Sudan, are there any memories you have of key moments where you had to change what you were doing to do something that was useful?
Probably on a daily basis. But when I think about working there, I do have a lot of memories of the work, memories of joy, but also memories of extreme frustration. I remember there was, we had a few children, one child in particular that had a femur fracture. He arrived at the hospital. He was about probably 10 years old, and he arrived with a closed femur fracture. And we were working with the Ministry of Health, and we were running the pediatric ward and we were running the maternity ward. They were able to do surgeries, but it was only for C-sections, for complicated deliveries. We didn't have a general surgeon nor any other type of surgeon. And so doing training in med peds, but never really, my last training or rotations in surgery were in medical school, trying to understand how I could help this child with the resources that we had and with the lack of some resources, and, working with a logistician to try and jimmy rig a traction, because we didn't have a traction set either. So we had to basically make up a traction set to keep him in traction for the femur fracture. I think that was fulfilling, but it was also frustrating to know that hopefully it's going to work. And I think that that's how I spent most of my mission, was crossing my fingers and hoping that things would work. I think that that's one memory that sticks with me. I don't know if that answers the question, but...
Yeah, no, it's a helpful one, because the sense that this might not work seems pretty important when one takes on complex things in other countries, people want to feel like they're making a difference. That's why they go overseas often. I want to feel like I'm making a difference. And then the first thing you encounter is, well, actually, this might not work.
Yeah.
How do you manage that tension?
I think one thing that I always have to remind myself, regardless of how many missions I've done or how many times I go out, every time I go somewhere new, I always spend at least a week or two just observing, because every place is different. Medicine is the same in theory, but the practice of medicine can be very different depending on where you are and how people react to it based on their religion, their culture, their socioeconomic status, their quality of life. So I think that I always spend a couple of weeks just trying to observe, because I need to remind myself that, and I think this is difficult for a lot of people that can do MSF or Doctors Without Borders or doing international work in general, is that sometimes you just end up going somewhere and you try to apply what you know from where you are, and that's not going to really work. You have to kind of shift your perspective and kind of see what's available to you, what your resources are in that setting, and see if there's a way that you could still practice medicine, but not necessarily limitations, but just in different ways than you're used to. So I think that that's something that I have to remind myself of every time I go out on a mission. And I think that, sometimes it's scary and sometimes you do the wrong thing, but sometimes you can, if you try and use the resources that are available to you and you just try and do the best you can for the patient, a lot of the time you can also see, people laugh at me when I say this, but it's true. I think I've learned also how medicine can be miraculous. There are miracles to medicine, and it's kind of an art. Some of it is very theoretical and it's very scientific, but some of it is also just trying to do what you can where you are and being persistent and and then sometimes, you can see outcomes that can be miraculous that you don't expect.
Can you remember any sort of quasi-miracles if they're not fully miracles?
I think when I was in South Sudan, there was a fair number of children that would come to us with very severe burn injuries and kind of injuries related to snake bites and necrosis of the tissue and the skin. I remember one boy who had a seizure disorder who came to us because he had a seizure and he fell into an open fire. And he also had developmental delay. And so he had burns from his face all the way down to his toes, probably about somewhere between 40 and 60%. And, I didn't know if he was going to live. And, like I said, there was no surgeon. So I had to do dressings on him every 2 to 3 days. And, we didn't know if he was going to survive, if he was going to get an infection. He had developmental delay. So especially the burns on his face, every time we wrapped them, he would unwrap them by the next morning. So we ended up keeping him in the hospital for probably over a month and a half, devised like boxing gloves for his hands so that he wouldn't remove his dressings once we did dressing changes on him. And, he had some scars, but he survived and we were able to discharge him from the hospital. I remember I had a patient when I was in Madagascar that had developed necrotizing fasciitis of her buttocks and her hip because she received intramuscular injection from a local doctor, probably with an infected or dirty needle. By the time she arrived to us, it was about almost a week later, and she had already started to develop necrotizing fasciitis. And again, we were working in a hospital supporting the Ministry of Health, but there was no surgery available at this hospital whatsoever. And so she stayed at the hospital with me, and there was no surgical team. So I was doing moderate sedation on her and doing her dressing changes with my team every 2 to 3 days. She stayed in the hospital with us for almost 3 months, but she was able to successfully get discharged and walk again.
There's some risk of losing a limb with that. Isn't that right? With necrotizing fasciitis, if it progresses, you might not keep your leg.
Yeah, and she had it bad enough that it was relatively localized. It mainly kind of affected the tissue and the muscles in her buttocks, spread to the other side on her right hip and her right buttocks. but luckily didn't extend down to her legs or to her spine. But it was myself. I had myself doing the dressings with a nurse that I was working with. And then I had the midwife monitoring the patient while we administered sedation on her for the dressing changes.
When I think about trying to do those tasks, in principle, I could. I'm a physician. I'm capable of some level of detachment. And at the same time, I sort of envisioned that I would be a little freaked out, that some part of me would be thinking both, I haven't really done many of these before, and this is a human life, and there's no backup, and all of this might fail. And to me, those fears would be pretty prominent. Did you feel afraid like that or not really?
I had worked in a pediatric emergency room, so I was relatively comfortable with moderate sedation, but doing the dressing and doing the sedation and asking somebody else to kind of keep an eye on things, but have to let them know what we need to be looking out for. There is definitely a piece of you that's scared that whether you're doing the right thing or not. But a lot of the time, like I said, I would take like a couple of hours, depending on what the problem was and how quickly I needed to react. I would kind of step back and think, am I doing the best thing for this patient? Am I doing the best thing right now? Should I wait? Should I think of sending them somewhere else? But a lot of the time, there's not really another option. So you just have to try and do the best you can and hope that it will work out. And sometimes it doesn't. And those are difficult times too.
Yeah. How do you cope with the moments when it doesn't work out?
I think for the cases that there was a negative outcome, I think for me, I always just think about the case and think about my thought process and, how the team or myself decided to intervene for the patient. Trying to, if there are certain things to learn, we always try and debrief and talk about it to see if there's some things we could learn for the next case. I guess I kind of hold on to them always as a memory, just as a reminder to try and do better next time. But to also understand that sometimes you can only do the best you can in those situations.
Yeah, I think the title of Saul's chapter, Healers Are Realists, assumes that we don't get to be victorious in all of these situations.
No, that's for sure.
You're taking on some leadership roles, or at least organizing roles, as you've progressed in your career. That's how I understand it, that sometimes you're responsible for projects rather than just direct frontline healing. Can you talk a little bit about that transition and what that's like?
When you work for Doctors Without Borders, generally your initial missions, especially as a doctor, depending on what kind of doctor you are, you go into missions being a clinician and practicing medicine. But then generally after a few missions, I think after probably my third or fourth mission, you have enough experience and you know MSF enough that they usually have a higher need for people in higher positions and managers than they do have a need for people to be practitioners or clinicians. So starting from probably my fourth or fifth mission, I started to take positions where you have more responsibility, whether you're involved in the daily clinical work or not. My previous 4 missions, at least my previous 4 or 5 missions, I've taken on a role managing national staff as well as other MSF expatriate staff that are there, and managing a medical team depending on the project and what our strategy and operations are.
What are some of the unique challenges of managing a team like that? It can sound a little dry at a distance. Management always sounds dry compared to frontline stuff. That's why there's not a lot of TV shows about managing healthcare operations. So is it in fact as dry as it sounds, or does it actually have something that we should know about it that makes it interesting?
I think that especially going on missions and being in these projects and working for Doctors Without Borders, there's definitely challenges in managing, especially managing a medical team that's usually very diverse internationally and has multiple different doctors from different countries and different backgrounds, which can be challenging. But I think that if everybody can understand what the need is and what the objectives and the priorities of the project are, it can be really fulfilling because you're kind of working together as a team and you usually have very clear objectives and priorities. I mean, there's so many different parts. You learn a lot about how important every part of it is and not just being the doctor, because if you don't have a generator working, then your oxygen is not going to work in your unit. And if you don't have clean water, you don't have some type of way to get clean water on a daily basis. That's obviously going to affect your activities. If there's contamination in the water system of the hospital that you're working in, that can have, significant effects on your activity. And I think that's also that part of it that is really interesting to me, is that you get to look at it on such a global scale. You get to understand the project, whether it's a hospital or a clinic or whatever it might be, but you get to look at it at a very different perspective, more globally, to understand all the other aspects that are necessary for the objective and the outcome that you're looking for.
Do you ever have to solve engineering problems?
Thankfully, there's usually always a logistics person there that kind of helps you with these things. But, you do work very closely with the logistics teams. If you have a WATSAN or a water sanitation engineer in your team, you're always looking closely at every single aspect, whether it's infection control or the water system. I've had situations where this recent mission, we had wall oxygen available in the hospital, but the system that was providing it was a very old system. So we would get these like pressure alarms every couple of weeks, and we would have to kind of shift to a backup oxygen in every, when you have surgeries running, and backup oxygen into different parts of the hospital, which is something that I would never probably ever significantly have to deal with here in the States as a doctor. Or when I was in Bangladesh, we were working in the refugee camp, and there was a water system that was implemented, and boreholes that were dug, and water pumps that were put throughout the camp by ourselves and other NGOs. And, we had to look at the data that we were getting in our outpatient department clinics, and seeing when we saw kind of peaks in certain diseases, skin diseases, diarrhea, trying to map where those people were living in the camp, and then working with the water and sanitation engineers to understand if there was something wrong with the water system. In that sense, working closely with other aspects that are non-medical, but definitely have an effect on the health of a community. And I find that interesting. I find it very interesting to kind of look at those links and think of those things other than just, taking care of the patient on a daily basis.
So far, we've talked about this a lot in terms of what you do and what impact you're trying to have and what adjustments you make. I wonder if we can try to think about this from the other side, which is you appear in a country, you're an American who I guess some people would recognize as looking Indian.
Yeah.
Do you get feedback, guidance, or reactions from the people that you aim to work with or that you aim to help? How do they see you?
I think it depends. I always try and go into it with a attitude of always having immediate respect for the people that are working for us, especially the national staff, because in a lot of these settings, the national staff are generally coming from that community and working with us, and are usually a majority of the staff that we have in these projects. So when you look at any MSF mission, usually you'll have a core expatriate team, depending on what type of project it is, but about close to more than 80% of the people that are working on a daily basis, whether it's clinicians, hygienists, those positions, more than 80% of them are filled by national staff. And they're there all the time in these difficult contexts, working, and we're kind of visitors there in their country and their world. And so I usually always try and understand and work with the national staff, and always go with an immediate respect for them. And then I feel like I said, I'm kind of a visitor there. So, you're trying to bring something into the project. There's a reason that you're there. You're trying to obtain objectives. You're trying to work with the strategy of the organization and what we're trying to do there. You're trying to improve technical competence, whatever it might be. There's a purpose that you're there. But I always try and understand and have it be a dialogue with the other staff, especially the national staff. I try and go into it with trying to gain their respect so that they understand what my purpose is being there, and try and show them that, it's the purpose of me being there, or the objectives that we're trying to accomplish are kind of for everybody, not just for MSF or just for me, but it's also for them, for the project, for the community, for the patient. And I think usually if I can successfully approach it in that way with a dialogue with the other staff, then usually those are my most successful missions.
Both Saul and I had brief periods of time in other countries, and at least one of them involved some real conflict where the expatriate staff expected people to appreciate exactly why they were there and expected to be somewhat honored for their willingness to sacrifice to come to the other country. And then they were miffed that people didn't really seem to admire them to the extent that they were used to it. And they wound up leaving a bit early, actually.
Yeah, that still happens today. I think people do this type of work always for good reasons, but for different reasons. And I think that there's always a good intention whenever, for the most part, whenever anybody's deciding to volunteer their time and their competence for Doctors Without Borders or any other organization that does international work. But, I feel like sometimes it's a good fit and sometimes it's just not a good fit, whether it's the context or whether it's the person that makes it not a good fit. And I've seen both sides of it. And I try not to be judgmental, but I also, there's people who do short missions, especially technical surgeons, anesthetists, people that come for short periods of time to projects that have been running for years. And some people go in with an idea of what they're supposed to accomplish. And, they want to do good and they want to accomplish something and they have objectives and priorities. And sometimes it's hard to understand that you're not on your schedule, that there's something that's been in place and existing for a while. And I think that that's something that's difficult because everybody wants to feel that they're accomplishing something and they want to have a positive feeling leaving. If they've volunteered their time and their energy and they've left their family, they want to, if they go somewhere for a month and a half, they want to feel like they accomplished something. But in some of these missions, you can accomplish a lot in a short period of time. In some of these missions, it takes time to get the respect of the staff and to accomplish these things. And I think it's difficult to kind of sense and know which situation or which context you're in. And I think for me, I'd have to say one of the reasons I continue doing this work is I remember after my second mission in Ethiopia, I was a little bit disheartened because it was a mission where I went to and I was very excited to go there. We were there opening up the project and I was the only doctor in this small village for close to 100,000 people. And at the end of my mission, I didn't really understand why I was there and what the medical need was. And I think that there was much more of a kind of geopolitical strategy in us being there, just wanted to have a presence in that area. And I felt kind of betrayed as a doctor as to why I was there. And I remember leaving that mission and kind of debating whether I was going to continue doing this type of work. And I remember talking with one of my colleagues and friends that I did my international fellowship with. And she told me, yeah, but you're really good at this. You're really good at it. She's like, so just give it another try. Do one more mission, try and see if you can get something out of it. And so I was able to have MSF sponsor me to learn French. And then I did another mission in French after that and kind of never looked back because I feel like, there's not a lot of people who are good at doing this type of work and continue to have a desire or an energy to continue doing this type of work. For the most part, I think almost every mission, I've definitely had several moments where I felt completely overwhelmed. But at the end, I'm kind of able to kind of put my head down and try and focus. And yeah, like I said, there's not a lot of people who can do this type of work. It's kind of like my little gift. So I shouldn't just keep it for myself. I should spread it around a little bit if I can.
Yeah, I think a lot of people, when they feel completely overwhelmed, the normal response is, well, I will never repeat that experience again. I should not do that again. And you've gotten to a point, it sounds like, where you feel overwhelmed and that's just part of the process. Did I hear you right?
Mm-hmm. Yeah.
So in a period of 3 years, how many of these 3 to 7 month missions would you do? Is it one every 3 years or one every year? Or
God, it varies. I'm also very poor at planning my life. So I've never been able to say what I'm going to be doing in a year or two, I don't think, since I finished my training in my residency. And I think just kind of being in training and residency for so many years, once I finally got out, I started doing MSF, Doctors Without Borders, immediately after I finished my fellowship. And at that time, I was doing more longer missions. So I was doing missions from generally anywhere from 6 to 9 months. And it would vary. So I would do like 1 or 2 missions back to back. And then about every year and a half to 2 years, I would try and come back and work in the States just so I could kind of keep up my clinical skills as being a doctor in the United States. And it varied. So I did a lot of, in the beginning, from 2008 to 2012, I would say I was probably doing more long-term missions, 1 or 2 back to back. And then I would work in the States for 6 months. And then I would go back out on mission and do that I did that for several years. Then I went to Oman, and that was for about 16 months. And then after that, I took a couple of years off because I had to do my board certifications for peds and internal medicine. And I had some personal issues that I had to stay stateside for. And at that time, I started working with this group I work with right now outside of San Francisco as an internal medicine hospitalist. And I switched my career in the States too. I used to only do pediatrics for the most part when I was coming back from missions. And then in 2012, I decided to switch for another challenge and try and go back to internal medicine. And so I've been working with this group since 2000, on and off since 2012. And since I took the couple of years off from 2014 to 2016, after that, I knew that I would want to go back to MSF. And I was lucky enough to find this group that I'm working with now that I'm able to try and negotiate time on a yearly basis to take some time off for missions. So usually now I'm going anywhere from 3 to 6 months, depending on my work and the group and how things are going and what I would like to do and what they're comfortable with me taking time off for.
What's your goal in the States? What do you want to have happen when you're here in the United States?
Make money. I think because I know that in the long run, probably I will at some point be going back, longer term, full time with Doctors Without Borders at some point in the future. And, I still have medical school loans that I have to pay. And I'm still trying to live a life that I'm comfortable with, that I feel like is fulfilling professionally and personally. So I think when I come back to the States after a mission, I enjoy things so much more. I enjoy going to the market and having so many choices. I take less for granted what I have here. And I enjoy, having my family and having access to them and spending time with them. But I think that the main, when I'm here, I also, like I said, am very lucky to have found a group that I really enjoy working with. And so I'm able to work with people that I like in an environment that I like, and I'm still able to make some money because I think the idea of just kind of long term, when I decide to retire, I just want to be able to be a little bit comfortable. And I know that doing missions is something that fulfills me personally. But I know that I take a little bit of a loss in terms of being able to pay off some of my loans and think about kind of being comfortable when I retire.
I know it's kind of a funny question, but when you talked about your family sort of seeing 3 possible visions for what would be a good job for you to get,
Mm-hmm.
I had some pressure like that as well. My parents were immigrants, and I both aligned with what they sort of wanted and then managed to choose the most disadvantageous branches of what they proposed I should do. Like, I'm writing proposals. My father's one wish is that I would never have to write proposals. I do homeless healthcare, which they admire, but they understand isn't as remunerative. Have you had to negotiate a little bit backwards with your family that your work is that of a doctor, but not quite what they might have had in mind?
Yes. Definitely. My mother continues to call me a gypsy and wonders when I'm going to settle down and, in her words, get a real life. But she's accepted it now. She kind of understands that this is not a phase anymore. But when I first started doing MSF and when I first started doing missions, she called me a gypsy and she said she didn't really understand why I went to school for all those years to do this. But I think as the time went on and as I continued to do it, and especially now that I'm kind of able to maneuver a life in both worlds. She feels a little bit more comfortable with it. And I think that she understands that this is my medicine. This is what I find fulfilling. It's not just a job for me. It's something that I feel like I'm good at. It's something that I enjoy doing. And it's something that I feel like gives me purpose, which is for me something when I went into medicine, I didn't want it to just be a job. I knew it needed to be something that was going to give me some sense of fulfillment or meaning in my life.
So many immigrant families come here with a vision of the American dream, and it's economic stability,
Yeah.
jobs, it's the suburbs, and then their children defy that. And it's an explanatory task to explain to them this is also the American dream.
Yeah. I think my mother found it very unnerving when I started MSF. I started MSF in 2008. And I think besides going to medical school and doing my training in Chicago, I don't think I ever lived in one city or one place for more than 6 months from 2008 until I think 2015. And so, it makes her nervous. And I think that's one of the reasons I still have this desire to come back to the States and work and make sure that I have some economic freedom and I still can try and take care of myself in the long term monetarily. But she understands it now, and she understands that it's kind of not just something I want to do, but it's kind of become part of who I am now.
Yeah, it sounds like at the beginning, this looked like a luxury you were taking on for yourself.
Yeah.
So it reminds me of a quote by the second American president, John Adams, who wrote, "I must study politics and war that my sons may have liberty to study mathematics and philosophy." The notion that I'm doing the hard-nosed stuff, not so that the next generation will do yet more of that, but that they might expand in a way that goes beyond where I live and what I do. And that's not easy for first generation children to negotiate with their immigrant parents. I can say that from experience.
Mm-hmm. Yeah.
If somebody were to come back from their first experience overseas and say, I thought I was going to make a big difference. It was terrible. I saw a lot of people die. I didn't feel like I was appreciated. It didn't work out the way I expected. What would you say back to them?
I think I would probably ask them first about what was their expectation when they went there, and what did they expect to accomplish when they got there. And then I would probably ask them about their worst experience and their best experience while they were there. Because, like I said, some people, even though they have a desire to do this type of work, in some cases, either because of the context, because of the team you're with, because of the work that you're doing, or because of what your expectations are, it's not always a good fit. But it could just be that one experience. So I think it's hard. There's no one answer, but I think for some people, they have that experience and maybe it's not the best thing to try it again or to try something similar to it, but maybe with a different organization. Because some people, it's the different international organizations are slightly different in the way that they do this type of work. So sometimes it's just a matter of fit. They don't fit with a certain organization, they fit better with another organization. But sometimes, it's the person. It's hard to know. I always try and let people know that, depending on what they say their best and worst experiences, just if you can try and have an open mind and less expectations, that's usually will serve you better than having clear ideas or expectations of what your experience is going to be. Because I think when you do this type of work, not that it doesn't live up to your expectations, but it's just such a different experience every time that it's better to be open to it, but not necessarily have expectations and just try and have the idea or the attitude of you're going to try and do the best that you can based on what the context in the situation is.
I completely identify with that because both times I went to Africa, roughly halfway into 3-month periods, I had to achieve a reset and abolish what I thought I was going there to do in order to receive and learn what it was I was actually going to be there for. And it helped a great deal, but it was a hard transition for me. The other realistic thing I heard you say is that when I gave you the scenario of what would you say, Your response was to ask questions, not to assume that there's something to say, there's something to ask, which is probably a very important sign of your experience, actually.
We've come to the end of part 1 of our interview with Dr. Naina Bhalla. In part 2, which is the next episode, I pick up the interview, asking Naina to elaborate on what it means and what it takes to be good at the practice of international medicine.